Hello friends, today we are going to discuss about the seizure disorder. So the status epilepticus is the neurological emergency. According to the International League Against the Epilepsy, status epilepticus it is a condition resulting either from the failure of mechanism responsible for seizure termination or from the initiation of mechanism which lead to the abnormally prolonged seizure. So, it is defined. The proper definition of status epilepticus is tonic-clonic status epilepticus. It is the most lethal and commonly encountered type, and it is defined as 5 minutes of continuous convulsive seizure activity, or two or more clinical convulsive seizure with incomplete recovery of baseline mental status in between. Now, the status epilepticus is divided into following type. Tonic-clonic status epilepticus, including unusually prolonged generalized tonic-clonic seizure, or where the patient does not regain consciousness between the repeated tonic-clonic seizure. Now, the focal status epilepticus with the preserved awareness, and it is characterized by the continuous and the repetitive focal seizure without loss of awareness. Now, what is non-convulsive status epilepticus? So, it includes generalized forms such as absence status epilepticus and focal status epilepticus with impaired awareness. So, the non-convulsive status epilepticus is also used to describe continuous seizure activity of patients who are comatose but have few other clinical signs. Anoxic myoclonical status epilepticus, which occurs following cardiac arrest, and it is characterized by the frequent, often stimulus-induced myoclonic jerk, which is time-locked to the malignant EEG pattern. Now, the tonic-clonic status epilepticus, it is the most generalized tonic-clonic status epilepticus, begin with the focal onset seizure that have secondarily generalized to tonic-clonic conversion. Most patients do not actually convulse continuously, but rather recurrent seizure lasting several minutes each are separated by the intervening period of prolonged unconsciousness without return to the baseline mental status. So during tonic-clonic status epilepticus, massive autonomic discharge occur with tachycardia and hypertension. Corneal and pupillary reflexes are lost and plantar reflexes may be extensive. As status epilepticus continues, the motor manifestation may progress into more subtle activities such as focal twitching, nystagmus, gaze deviation, or recurrent pupillary hippus. Among patients who are encephalopathic, status epilepticus may first present in this more subtle form without observed convulsive activity, and EEG is required to confirm the diagnosis for these cases. Of note, myoclonic status epilepticus with repetitive and asynchronous myoclonus with variable clouding of consciousness is often classified as a form of convulsive status epilepticus and may progress into generalized tonic-clonic status epilepticus. Now, focal status epilepticus with preserved awareness. The focal status epilepticus with preserved awareness is the second most common form of status epilepticus after generalized tonic-clonic status epilepticus. In focal motor status epilepticus, clonic activity is localized usually to face or an extremity. And this activity may spread corresponding to the somatotopic organization of motor cortex, also known as Jacksonian march. Alternatively, the focal motor seizure may be multifocal and often precipitated by the metabolic disorder such as hyperglycemia with the hyperosmolar non-ketotic state. Now, this epilepsia partial continua is the particularly prolonged form of focal motor status epilepticus, characterized by the continuous, highly localized seizure that do not generalize and in which consciousness is maintained. So, the focal motor status epilepticus typically respond to medications such as phenytoin and other standard agent, including levetiracetam, but epilepsia partial continua can be notoriously resistant to the treatment. Now, the next type is non-convulsive status epilepticus. This non-convulsive status epilepticus is the under-recognized cause of coma or persistent unexplained encephalopathy. In one study, the non-convulsive status epilepticus was present in 8% of all comatose patients studied without sign of clinical seizure activity. In other studies, a third of the patient with unexplained altered mental status in ICU were in non-convulsive status epilepticus. So the non-convulsive status epilepticus is more likely to occur in the setting of acute medical problem, both systemic or neurology. So non-convulsive status epilepticus include absent status epilepticus and focal status epilepticus with impaired awareness. Previously, the dyscognitive feature. Clinically, both present with the prolonged period of altered behavior and can masquerade as a psychiatric fugue state. So, non-convulsive status epilepticus can be defined clinically as prolonged confusion state of 30 minutes or longer, involving variable level of altered consciousness. Now, next is absent status epilepticus, which may be accompanied by subtle myoclonic movement of the face, eye blinking, and occasionally automatism of the face and hands. The EEG is diagnostic, revealing continuous generalized spike wave activity. So, the focal status epilepticus with impaired awareness involve a state of continuous focal seizure with combination of staring, unresponsiveness, language disturbance, motor automatism separated by the confusional state or more prolonged state of partial responsiveness and semi-purposeful automatism. And the EEG can either and EEG can show either recurrent focal involving seizure activity in one or more location or continuous focal rhythmic or periodic pattern. Now, the next type is anoxic myoclonic status epilepticus. So, among adult, the myoclonic status epilepticus is most commonly caused by toxic or metabolic encephalopathy, most commonly by the severe hypoxic ischemic encephalopathy, which is resulting from the cardiac arrest. When the recurrent myoclonus occur in this setting, the patients are usually comatose and the prognosis is poor. This anoxic myoclonic status epilepticus represents the severe stage of post-anoxic coma. This clinical entity is typically associated with the malignant rhythmic or periodic pattern on EEG, such as generalized periodic discharge, or in some cases, even frank seizure. When this finding occur in the setting of multiple specific EEG features, such as persistent discontinuity, background suppression, and unequivocal seizure or lack of EEG reactivity, the prognosis is almost invariably poor. In this setting, many experts feel aggressive treatment is not warranted. Of note, care must be taken to differentiate malignant anoxic myoclonic status epilepticus from more benign form of post-anoxic myoclonic syndrome, known as Lance-Adams syndrome. So, regarding etiology, symptomatic status epilepticus resulting from acute or chronic neurological or metabolic insult is at least twice as common as idiopathic status epilepticus. That is presumed genetic etiology for seizure in otherwise neurologically normal person. In adult, the major cause of status epilepticus is stroke or changes or decrease of anti-seizure drugs. So stroke contributes to 22% of cases and changes or decrease of anti-seizure drug contribute to 34% of cases. The other etiologies include autoimmune encephalitis, including limbic encephalitis or diffuse encephalitis, which may have paraneoplastic or non-paraneoplastic cause. New onset refractory status epilepticus refers to bout of refractory status epilepticus due to unknown causes, some of which were proven to be either infectious or autoimmune etiology. Now, the etiologies of status epilepticus: structural brain lesion, brain trauma, brain tumor, stroke hemorrhage, then central nervous system infection, then autoimmune encephalitis, systemic infection, and sepsis. Then drugs like toxins such as theophylline, lidocaine, carbapenem, and penicillin. Withdrawal state like alcohol withdrawal, benzodiazepine, or withdrawal caused because of benzodiazepine and barbiturate. Then anti-seizure drugs, then non-adherence to the medication, errors in medication, or any change in prescription of the anti-seizure regimen, or because of the altered drug absorption or drug-to-drug interaction. Now, there are few metabolic causes of seizure like hypocalcemia, hypomagnesemia, hypoglycemia, hyperglycemia, and hyponatremia. Now, it may be caused because of the hyperosmolar state, anoxia or hypoxemia, uremia, and hepatic dysfunction. Now, regarding prognosis and sequelae of the status epilepticus. So the mortality for status epilepticus depend upon the specific etiology, duration of episode, and age of the patient. Cerebral hypoxic ischemic injury has been associated with highest mortality, and alcohol withdrawal and ASD discontinuation with lower mortality. So if the patient is having idiopathic status epilepticus, then it has a relatively low mortality rate. The duration of the convulsive status epilepticus longer than 30 minutes and age over 70 significantly increases the mortality. Despite the modern medical care, tonic-clonic status epilepticus still have average mortality rate of 20%. The mortality of the focal status epilepticus with impaired awareness was 18% in one study. Other adverse outcomes include resultant cognitive impairment, permanent neurological deficit, and chronic epilepsy. The status epilepticus itself can produce profound neurological damage. So, neuropathological studies of the brain of children and adults who died shortly after status epilepticus reveal ischemic neuronal changes in hippocampus, middle layer of cerebral cortex, cerebellum, basal ganglia, thalamus, and hypothalamus. So, these changes mimic those of severe hypoxemia and hypoglycemia. Hyperthermia during episode of status epilepticus has been shown to correlate closely with the degree of CNS damage. Now, this perpetuation of the status epilepticus is caused by imbalance between excitotoxic mechanisms like glutamate mediated and inhibitory mechanisms like GABA mediated. So, the downregulation of these GABA receptors or excitotoxic mechanism involving glutamate receptor, both NMDA and non-NMDA receptors are involved. So the calcium influx which occurs during excitation is the critical component of neuronal injury and cell death with activation of protease and lipase, leading to degradation of intracellular elements. Now, this abnormal neuronal activity alone can cause permanent neurological injury. Now, the patient with the focal status epilepticus without concomitant hypotension, hypoxia, or hyperpyrexia can still have subsequent neurological injury in specific region of the brain associated with the ongoing seizure. Now, the chronic memory impairment which may follow the focal status epilepticus with impaired awareness and focal neuronal necrosis and edema has been found after focal motor status in the involved brain region. Now, the focal MRI changes are often seen after prolonged epileptic activity, particularly on diffusion and perfusion MRI, though these changes may dissipate it over time. Mortality of the non-convulsive status epilepticus with pre-existing epilepsy is lower compared to non-convulsive status epilepticus following acute medical condition. Now, regarding systemic complication. If convulsive status epilepticus is not terminated promptly, secondary metabolic and medical complication may occur. Hypothermia may follow this excessive tonic and clonic muscle activity, or hypothalamic dysfunction can occur, or it may be caused by underlying infection responsible for status epilepticus. Both hyperthermia from infection and that from the status epilepticus per se can be accompanied by the peripheral leukocytosis due to demargination with the white blood cell count in the range of 12,700 to 28,000. The differential may be normal or may show lymphocytic or polymorphonuclear predominance, but band forms are rarely present. A mild CSF fluocytosis can occur during status epilepticus, and the maximum cell count is usually less than 80, with initial polymorphonuclear predominance that revert to the lymphocytic predominance as fluocytosis resolve over a few days. A mild transient elevation of CSF protein may also occur. Lowering of the CSF glucose level does not occur, and reduced CSF glucose should raise concern for underlying infectious or inflammatory processes. Now, the medical complication of status epilepticus. So, if you're talking about cardiovascular complication, then patient can have hypertension, tachycardia, arrhythmia, owing to the autonomic overactivity, which may further complicated by the shock due to lactic acidosis or by pharmacological intervention for the status. Now, regarding respiratory system complication, respiratory dysfunction may be caused by the mechanical impairment from tonic muscle contraction, disturbed respiratory center function, autonomic overactivity, and producing increased bronchial constriction and secretion. And the later complication include apnea, aspiration pneumonia, and neurogenic pulmonary. Now, the renal system complication, the renal impairment may occur from the combination of rhabdomyolysis with myoglobinuria and hypotension with poor renal perfusion. Later complications include uremia and the acute tubular necrosis. Now, the metabolic complication, increased lactate production from maximally exercise muscle results in the metabolic acidosis within minutes after start of status epilepticus with variable respiratory contribution to the acidosis from carbon dioxide retention. The degree of acidosis does not correlate with the extent of neuropathological damage. After cessation of seizure, lactate is rapidly metabolized, resulting into the spontaneous resolution of the acidosis. Systematically, hyperglycemia initially developed owing to the catecholamine and glucagon release. And then after that, hypoglycemia may occur due to increased plasma insulin, increased cerebral glucose consumption, and excessive muscular activity. Now, regarding diagnosis part, so as I mentioned before, status epilepticus is medical emergency, and it must be diagnosed and treated immediately in critical care setting. Now, the pharmacological intervention is more effective at early stage of status epilepticus than after a delay. Now, the treatment must be categorized into these 4 points. Like first is termination of seizure. Then we have to we have to prevent the recurrence of seizure. Then we have to identify the underlying etiology, and then we need to treat the complication. So, initial step is to confirm the diagnosis of seizure. The diagnosis of generalized tonic-clonic seizure, or it may be focal seizure, it is usually initially made on the clinical basis. In any of these cases, treatment should be initiated on clinical basis. Now, the prompt treatment should not be delayed for the diagnostic confirmation with continuous EEG, though the continuous EEG is often useful when available to ensure ongoing seizure have terminated as expected. A flurry of isolated seizures separated by the normal level of consciousness does not constitute a status epilepticus, although urgent treatment may still be required in this case also. Now, non-convulsive status epilepticus may present clinically with only non-specific encephalopathy and a situation that is often underdiagnosed, leading to the treatment delays. In more ambiguous cases, such as this, continuous EEG is often necessary to confirm diagnosis prior to the initiation of treatment, especially when there are significant risks associated with the treatment. For diagnosis of non-convulsive status epilepticus, certain well-defined EEG criteria need to be met. Continuous EEG use is associated with the lower mortality rate. Now, the next terminology is electrographic status epilepticus. To diagnose non-convulsive status epilepticus on purely electrographic basis, there must be continuous electrographic seizure activity for more than or equal to 10 continuous minutes. In this case, the electrographic seizure activity can be defined as any pattern with definitive electrographic evolution or sustained epileptiform discharge averaging more than or equal to 2.5 minutes. Of note, this continuous epileptiform discharge may take the form of generalized or lateralized periodic discharge or spike wave activity. Now, the next terminology is electroclinical status epilepticus. To diagnose non-convulsive status epilepticus using combination of both EEG and clinical criteria, there must be more than or equal to 10 minutes of continuous electroclinical seizure activity. That is any definite clinical symptom that is time locked to the EEG pattern, or more than or equal to 10 minutes of suspected electrographic seizure activity with both EEG and clinical improvement following treatment with parenteral anti-seizure drug. Of note, specifically in case of generalized convulsive seizure, more than or equal to 5 minutes of seizure activity meets the criteria of uh, electroclinical status epilepticus. Now, the next terminology is possible electroclinical status epilepticus and the ictal interictal continuum. This term apply when there are persistent rhythmic and periodic EEG patterns that do not meet the formal EEG criteria for electrographic seizure, but may be contributing to impaired awareness and neuronal injury or causing the other clinical symptoms. For example, when there is a persistent periodic pattern, not meeting the formal criteria for this status epilepticus, and it improve with the parenteral anti-seizure drug, but does not show clinical improvement. This would be considered possible electroclinical status epilepticus and often represents the intermediate clinical situation. In this case, the consultation with neurology or epilepsy physician, when available, is recommended to determine the best management in these cases. Now, regarding initial assessment, once the diagnosis of status epilepticus is made, it is important to perform a rapid initial assessment of medical stability and workup of potential etiology. Obtain as much history as possible within the first few minutes, including any history of pre-existing epilepsy and anti-seizure drug, alcohol or illicit drug abuse, or any recent neurological incident. The examination should focus on the signs of systemic illness such as uremia, hepatic illness, infection, illicit drug use, evidence of trauma, or focal neurological abnormalities. After appropriate blood samples have been obtained, the glucose administration is recommended given that hypoglycemia is rare but easily reversible cause of status epilepticus. Because glucose administration may precipitate Wernicke-Korsakoff syndrome in patients with poor nutrition, intravenous thiamine should be given prior to the glucose. Subsequent IV infusion should consist of saline solution because some anti-seizure drug might precipitate in the glucose solution, and the patient must be reassessed for other metabolic consequences of status epilepticus. Hyperthermia should be treated and oxygenation may be maintained. The metabolic acidosis that occur does not adversely affect the neurological outcome and does not need the treatment with the bicam. Now the next thing is the blood pressure that we need to monitor very carefully. Systemic hypertension and decreased cerebral vascular resistance of early status epilepticus provide adequate blood flow for increased metabolic demand in the brain, but eventually hypotension may occur, making brain vulnerable to the inadequate perfusion. So pharmacological intervention for seizure can exacerbate the hypotension. Now we'll see the rough management guideline for generalized status epilepticus in adult, and later we'll elaborate this treatment. So within first 0 to 9 minutes, if the diagnosis is uncertain, then observe for recurrence of generalized seizure without intervening recovery of consciousness or continuous seizure activity for more than 5 minutes. Then first take care of ABC. That means we need to establish first airway, pulse oximetry. We need to provide O2 if patient is hypoxic. Then provide appropriate cardiac monitoring. Establish IV access. Then look for the bedside rapid glucose determination. If hypoglycemic, give glucose that is 50 to 100 ml and give thiamine that is 100 mg IV. Then said lab investigation like CBC, electrolyte, BUN, create, glucose, anticonvulsant drug level, toxicology screen, and other lab as indicated by history and examination. Then next 5 to 30 minutes, within the 10 minutes, administered lorazepam that is 0.1 mg per kg IV, given 2 mg at a time. Or we can also give midazolam that is 10 mg IM. Or we can also use diazepam that is 0.1 to 0.2 mg per kg. The maximum dose that we can use is 10 mg per dose. Then within next 30 minutes, our aim should to stop the recurrence of seizure. So for that purpose, we need to administer phenytoin, that is 20 mg per kg at less than 50 mg per minute, or phosphenotoin 150 mg for phenytoin equivalent per minute. Slower rate in elderly or if hypotension or bradycardia develop. Then draw the blood for every 10 for level 10 minutes after infusion is complete. Then provide cardiac monitor, assess the frequent blood pressure, and careful observation of respiratory status and oximetry. Then EEG monitoring is possible. Consider additional 5 mg per kg bolus of phenytoin to maximize to maximum dose of 30 mg per kg if seizure persists. Lorazepam as needed for seizure during phenytoin load. So if we cannot use phenytoin or if it is contraindicated and seizure is continuous, then the alternative agent that we can use is levetiracetam, that is 20 to 60 mg per kg IV at 2 to 5 mg per kg per minute, or sodium valproate, that is 20 to 40 mg per kg IV at 3 to 6 mg per kg per minute. Then if we are using valproate, then watch for hyperammonemia, pancreatitis, thrombocytopenia, or hepatotoxicity. And we should also know that valproate has the teratogenic potential. Then the next drug is phenobarbital, that is 20 mg per kg IV load, and the total dose is less than 100 mg per minute. Then if we are administering phenobarbital, then we need to anticipate respiratory depression and need for the intubation. Consider for alcohol withdrawal. Then the next agent is lacosamide, that is 200 to 400 mg IV over 3 to 5 minutes. And the adverse effect of lacosamide is prolonged PR interval, first degree AV block, and bradycardia. Then next 31 to 90 minutes for persistent status, induce coma, intubate if not previously done. Then continuous EEG should be taken to monitor for seizure and level of anesthesia. So in that state, give propofol, that is 1 to 2 mg per kg IV bolus and 1 to 5 mg per kg per hour infusion. We need to note here that 5 mg per kg per hour is 83 mg per kg per minute. Then we need to monitor serum for lactate, triglyceride, CPK, BUN, and creatine. Or we can also administer midazolam, that is 0.2 mg per kg IV bolus, or we can also give it in the infusion form, that is 0.1 to 2 mg per kg per hour. Or the next agent that we can use is pentobarbital, that is 5 mg per kg IV load, given over 20 minutes or repeat as needed to produce burst suppression pattern on each. Complete EEG suppression may be needed if seizure activity persists during the burst. Maintenance infusion that we can administer is 0.5 to 5 mg per kg per hour. Then monitor serum for lactate, osmolarity, bicarb, and creat for propiline vacuum syndrome. Once burst suppression pattern is established on EEG, which is defined by 10 seconds of suppression with 1 to 2 seconds burst of cerebral activity, then we have to continue it for 24 to 48 hours. If burst contains the epileptiform activity, consider complete EEG suppression. Then we have to monitor EEG every 1 to 2 hours. Adjust medication dose as needed. Monitor for hypotension, ileus, propofol infusion syndrome, and propylene glycol syndrome. Continue maintaining dose of phenytoin, levetiracetam, valproic acid, lacosamide, or phenobarbital. Monitor and maintain therapeutic level. Then we need to taper anesthetic medication at 24 to 48 hours. If seizure recur, resume the infusion for 48 hours and then taper again. Continue this process as necessary. It is essential to determine whether metabolic disorder is causing status epilepticus, or if this is the case, then pharmacological intervention for seizure alone is not effective. Any systemic and CNS infection must be excluded, and lumbar puncture is often necessary. Contrast enhanced head CT can be useful after the patient has been medically stabilized. MRI is preferred due to high sensitivity for small and more subtle lesion, but may not be practical in the acute setting. Now, regarding medical management, so the same medical management will describe in brief. So, if so, as we have seen before, so first line treatments are always benzodiazepine. So these IV benzodiazepines are the appropriate initial treatment. And the Veterans Affairs Status Epilepticus Cooperative Study Group trial suggested that phenobarbital is also effective as initial therapy, but phenytoin alone without benzodiazepine may be less effective. So the diazepam and lorazepam are both effective for treating generalized status epilepticus. So, but the advantage with the lorazepam, it has long duration of action compared to diazepam. That is, duration of action of the lorazepam is 2 to 24 hours, and for diazepam, it is 10 to 25 minutes. And also, the lorazepam doesn't have any extensive peripheral tissue uptake, unlike diazepam. So, the penetration, the CNS penetration of the lorazepam is just slower than the diazepam, and the onset of action of less than 3 minutes. So, for this reason, the lorazepam is recommended first-line agent for status epilepticus. Both of these drugs have significant and essentially same cardiac, respiratory, and CNS depressant side effects. Respiratory depression and apnea, which are potentiated by age and previous administration of sedative drug, may occur abruptly with the doses as small as 1 mg. Hypotension, which occasionally occurs, may be partially caused by propylene glycol solvent contained in the IV form of diazepam and lorazepam. In 2012, the Rampart study showed that if IV access was not available, then the intramuscular midazolam was as effective as IV lorazepam for pre-hospital treatment of status epilepticus by paramedics, and this was not associated with increase in respiratory compromise or seizure recurrence. Then the early administration of adequate doses of lorazepam remains the preferred first-line treatment for status epilepticus in emergency department and other controlled clinical environment. Adequate dosing of the lorazepam is generally considered to be maximum of 0.1 mg per kg, which can be given in 2 to 4 mg IV boluses. Now, the rectal diazepam that we can be given in the dose of 0.2 mg per kg has also been successful for achieving rapid therapeutic level and effectively terminating prolonged generalized seizure. Significant respiratory depression from the rectal diazepam has not been reported. The intramuscular administration of diazepam is unsuitable for treatment of status owing to the delayed peak levels. Furthermore, the peak concentration after IM injection is much less than that after IV injection. The response to benzodiazepine may be helpful for confirming the diagnosis when it is in question. The patient should also be started on anti-seizure medication appropriate for long-term management, given as loading dose when appropriate. Now, regarding second-line treatment. Regardless of treatment response to the first line, the second line medication we have to give as rapidly as possible because to prevent the recurrence of seizure or status epilepticus. In the cases of patient with a known epilepsy or on other anti-seizure drug, this second line agent can be given in addition to their home medication. While fosphenytoin was the long considered the ideal second line agent, the 2020 ES-80 study has essentially revealed that fosphenytoin, levetiracetam, and valproate are equally effective at terminating status epilepticus when given at proper doses. So phenytoin was often given with the benzodiazepine to control status epilepticus and prevent the recurrence of seizure. Now, this IV infusion of phenytoin carries the risk of medical extravasation into adjacent tissues in which tissue necrosis can rarely occur. Like this syndrome is known as purple glow syndrome. For this reason, it's a product that is fosphenytoin is strongly preferred for treatment of status epilepticus to facilitate safe rapid infusion. The fosphenytoin is the water-soluble product of phenytoin and is rapidly converted enzymatically to the phenytoin. Rapid and complete absorption occurs after IM administration. Therapeutic phenytoin concentration is attained by most patients within 10 minutes of rapid IV infusion, that is 150 mg per minute, and within 30 minutes of slow IV infusion or IM injection. Fosphenytoin is dosed by phenytoin equivalent or mg phenytoin equivalent, and thus the dosing is same as that of the phenytoin. Cardiac monitoring is required during IV infusion of fosphenytoin. 20 mg per kg load is recommended for patient with the normal liver function. If seizure continues, additional dose of up to another 10 mg per kg can be given. The total serum level goal of phenytoin should be 20 to 30 mics per ml, which can be checked several hours after initial infusion. Of note, these level need to be corrected for serum albumin. Hypotension and electrographic changes and respiratory depression can occur, and it may be partly to propylene glycol dilute. Simultaneously, cardiac monitoring should be performed, and the slower infusion rate should be considered for patients who are elderly, owing to increased susceptibility to cardiopulmonary adverse events. So maintenance doses of the phenytoin and phosphenytoin should be started within 12 to 24 hours of loading dose. That is typically 5 mg per kg per day, divided twice or thrice times daily, or daily adjustment to maintain level in the high therapeutic range, that is 18 to 25 microgram per. Of note, phenytoin and phosphenytoin are often ineffective for treating absence. Now the levetiracetam, it is the synaptic vesicle release inhibitor, and it is a rapidly becoming one of the most commonly used anti-seizure drug in the clinical practice. This is in part due to relatively low adverse effect profile compared to the other IV anti-seizure drug. In ESETT, levetiracetam was given at 60 mg per kg IV load with a maximum of 4.5 grams. Notably, this is the considerably higher dose than what is typically given in many emergency and critical care settings. So the levetiracetam is the unique among the three main second line agent in that it is cleared renally, and it is an important consideration when treating patient with renal dysfunction. So valproate, it is the anti-seizure drug with the multiple mechanism of action, including blockage of voltage-gated sodium channel and increasing brain level of the GABA. While it has long been considered an alternative ASD for treatment of status epilepticus when phenytoin is contraindicated, the ESET trial has established it is equally efficacious to phenytoin when given at recommended 40 mg per kg of loading dose. Importantly, if valproate is given along with phenytoin or fosphenytoin, it is important to note that these medications significantly affect metabolism and serum concentration of one another given their respective effect on cytochrome P450 system. Now, this valproate will raise the phenytoin level, and phenytoin will lower valproate level, which can have unpredictable effect overall. IV valproate is well tolerated with relatively fewer adverse effects in acute setting. So valproate level should be monitored and maintained between 80 to 100 mg for the treatment of status epilepticus. Of note, valproate is very effective for treatment of absence seizure as the levetiracetam. Now, this lacosamide is the slow sodium channel blocker, and it lacks the long history and strong evidence based of the prior three anticonvulsant drug. It represents the viable alternative agent that could be used if contraindication exists to others, and if the patient is already taking one or more more of other agents. Now, the lacosamide, when we are using, we should be using the dose of 300 to 400 mg when treating status epilepticus. Now, the next agent is the brivaracetam. It is the another SV2A blocker, which is similar in pharmacology to the levetiracetam, though varies in that it is metabolized in the liver and it is a considerably more potent. Similar to lacosamide, there is not the same strong evidence base for this medication for status epilepticus, but ample evidence exists to consider it as alternative drug. That is, whenever the contraindication exists to other medication, we can definitely go with the brevaracetam. Now, the next agent is phenobarbital. Phenobarbital is useful barbiturate medication that can be given at any stage in the treatment of status epilepticus, and it can be used at lower doses prior to the initiation of drug-induced coma in an attempt to avoid progression, or after intubation at considerably higher doses when another drug with a different mechanism is needed. With phenobarbital infusion, respiratory depression can occur, especially if benzodiazepine have been used. Phenobarbital may also be used as a bridge if initial weaning of phenobarbital results in the recurrence of seizure. Temporary supratherapeutic level of phenobarbital may be needed in this situation, that is 40 to 60 microgram per ml. Now, third line treatment that is used in the case of refractory status epilepticus. If status epilepticus persists even after initiation of first and second line agent, it is considered as refractory status epilepticus, and treatment from this point on may vary considerably and typically involve drug-induced coma. For drug-induced coma, the patient must be intubated. An agent commonly used for refractory status epilepticus include midazolam, propofol, and pentobarbital. All are extremely effective when used at proper dose for suppressing clinical and the electrographic seizure. Now, the continuous EEG monitoring is mandatory during induction of the coma. While initiating this infusion, the addition of other ASD is usually needed in preparation for when infusion are eventually weak. Now, the non-convulsive status epilepticus must be treated quickly, although additional trials of anti-seizure medication are often warranted prior to intubation and initiation of IV sedative agent. When needed, these medication doses are comparable to those used in the other type of status epilepticus. Propofol, which is GABA agonist, it is a potent anti-seizure agent. Propofol has the advantage of rapid induction and elimination, but downward titration is important to avoid recurrent seizure. One significant disadvantage of this drug is the propofol infusion syndrome, and it consists of profound hypotension, rhabdomyolysis, hyperlipidemia, cardiac arrhythmia, and metabolic acidosis. Of note, the doses of propofol used in the treatment of status epilepticus is considered higher than those routinely used for the sedation. Now, the next drug is midazolam. Midazolam is comparably well tolerated and effective. And compared to pentobarbital, patient on the midazolam has less cardiac depression and they regain consciousness more rapidly after discontinuation. Now, the midazolam can be used in combination with the propofol to decrease the risk of propofol infusion syndrome. Tolerance to the anti-seizure effect of the midazolam can develop after 36 to 48 hours, which can lead to escalating dose requirement. So there can be which is described as tachyphylaxis. Because of this, if status epilepticus is not terminated within 72 hours of midazolam treatment, changing to alternative infusions such as propofol and pentobarbital is recommended. Of note, the doses of midazolam used in the treatment of status epilepticus are considerably higher than those routinely used for the sedation. The dose of propofol and midazolam must be sufficient to terminate any seizure activity seen on the EEG. In many cases, the goal is to produce burst suppression pattern on EEG, which is characterized by the flat background of for at least 5 to 15 seconds, punctuated by the burst of mixed frequency activity lasting 1 to 3 seconds in duration. This burst suppression may be maintained for the period of 24 to 48 hours. If burst contains the significant epileptiform discharge, the coma should be deepened at times to virtually electrocerebral silence. During this time of drug-induced coma, it is essential to maintain high therapeutic level of all anti-seizure medication to avoid recurrence of status epilepticus upon eventual tapering of anesthetic agents. Now, the next concept is super refractory status epilepticus. In this case, either frank status epilepticus or persistent aggressive epileptiform activity on EEG despite drug-induced coma or additional treatment may be considered. So, pentobarbital infusion may result in cardiac depression and careful hemodynamic monitoring is required. So, the vasopressors are frequently needed and ileus is also common. Propylene glycol toxicity has been reported in patients treated with barbiturate coma for refractory status epilepticus. These patients can develop hypotension and hepatic and renal failure, and treatment may include hemodialysis. Of note, when pentobarbital is used, it typically results in diffuse EEG background suppression. Now, the high-dose ketamine is the another agent that can be considered for super refractory status epilepticus, especially when there are frank or relative contraindication to using pentobarbital. A prior study using ketamine for this indication was associated with the decrease in seizure burden. The high dose ketamine infusion was associated with decreased vasopressor requirement and were not associated with the increased intracranial pressure. Of note, there is relatively little prospective data to suggest that propofol, midazolam, or pentobarbital are dramatically different in efficacy for the status epilepticus. Several studies seem to indicate that patients treated with pentobarbital have fewer treatment failure and breakthrough seizure, but more frequent episode of hypotension. There is no clear difference in mortality among these agents. The ketogenic diet is the emerging non-pharmacological treatment of superrefractory status epilepticus. The high fat and the low protein and carbohydrate diet is administered via nasogastric tube, with the which subsequently induces the metabolic shift towards acidosis, resulting in ketonuria, which can be present within the few days of initiation of the diet. Successful treatment of superrefractory non-convulsive status epilepticus with ketogenic diet has been described in various literature. Now the properties of the drug. Now these are the drug that we are. This table is describing the drug that we are using in the termination for the seizure. So first line drug is diazepam and lorazepam. Diazepam that we can be administered in the two routes, that is IV and rectal. So loading dose of the diazepam is 0.1 to 0.2 mg per kg. We can administer it up to maximum 20 mg, and rate of the administration is 2 mg per minute. So time to enter in the brain is less than 10 seconds. Now the next drug that we can next benzodiazepine that we can be used is lorazepam, that we can use in the dose of 0.1 mg per kg, and the rate of administration is the 2 mg per. Now the second line drugs are phosphenotoin, that is 20 mg per kg. Maximum that we can use is the 50 mg per minute. Then levetiracetam, that is 60 mg per kg. The maximum that we can give to is 4.5 gram. Then valproic acid, that is 40 mg per kg, up to 3 to 5 mg per kg per minute, or even higher bolus rate can be given. And the last is the phenobarbital, that is 20 mg per kg. And if you want to give infusion is then the 50 to 100 mg per minute. Thank you.